Welcome to our latest episode on leadership and culture in healthcare. And we, in this series, are focusing on the independent sector. And I am delighted that Nick Costa, the Chief Executive of Ramsay Healthcare in the UK, has joined me. Nick, welcome. Why don't you introduce yourself and tell people a little bit about Ramsay to begin with, what it does, how it's working in the UK, so we can set the scene for this conversation.
Marcia, thank you very much for the opportunity today. I'm Nick Costa. I'm Chief Executive of Ramsay Healthcare in the UK. We're part of a global organisation that had its roots in Australia, and the reason I share that is because we share our 60th anniversary this year. So we're a long-standing organisation. Started out in mental health. Through acquisition through Australia, it's now the largest provider of both elective, acute, and mental health services in Australia. And over time, it's transitioned services so right throughout Europe, so in France, right through the Nordics and to the UK as well. And the reason I share that is because what's been at the heart of our organisation is about people caring for people. And the fundamental to that is, one, that longevity. It enables an organisation to think longer term and to really ensure that the culture that the organisation stands for stands side by side with the local health systems, and that's been a key part of Ramsay's growth strategy over the last 60 years. I'm really proud in the UK as well that we live and breathe that. So as an organisation, we're very, very conscious to work within and be part of our local communities. So whilst we have 37 operating units in England only, that multi-site management is going to be something we'll talk about today. But I think also, how do we instill and ensure that behaviour and culture pervades through our whole organisation? So that brings its own challenges. But a key element of that is making sure we're really strong citizens in our communities, with our teams and with the people that we partner and work with.
How did then Ramsay get to work in the UK? Was that an acquisition model that or are they just is it been organic growth in the UK?
Yeah, so many people won't be aware of it. And if you go into some of the old independent hospitals, you'll see the decor is very 80s. So historically, the independent sector came out with, so the NHS was formed, and then individuals over time, either through local charitable contribution or local doctor groups, typically started setting up small independent hospitals to carry on offering a private service. Bear in mind, it was all paid for prior to the NHS forming. And over time, those have grown. And as with most things, through acquisition, combination, lots of them formed into smaller groups, got slightly bigger, and then to the situation you've got now. So Ramsay came into the UK 15 years, so we're celebrating our 15th anniversary this year in the UK. And that was through an acquisition of a company called Capio, who at that point in time, I believe, were the largest healthcare provider in Europe. And since then, Ramsay has bought the whole of Capio as well in Europe, so, and combined that with its French operation. Hence, we've got a business that runs right through from right through France, right through up to the Nordics, and we run the UK as a separate business. The reason for that is the NHS is fairly unique, not totally, but fairly unique, and that all of the territories we work within all have a strong state system, and we see ourselves as a strong state partner. So the UK entry was key for the organisation, but also that real strong ethos of working with the NHS was already embedded within our predecessors, Capio, and we've looked to maintain and build on that.
Yeah, interesting. And just for people that don't know your portfolio, so you said 37 different units across the UK. Are they all acute and elective in the UK? Because you say in Australia there's mental health as well. So what's the portfolio mix in the UK?
So in the UK, we actually do have a mental health stream, which we acquired 3 years ago. It's called Elysium. That doesn't run under my remit. Mine's purely the elective part of the business. And Elysium is the largest independent provider to the NHS for mental health as well. But that can be a separate conversation. So we have 37 operating units, all elective work. We are not in central London, so we ring the M25 and then we cover every corner of the UK, strong clusters in northeast, northwest, southwest, southeast, and some Midlands coverage as well. We provide just over 3% of all elective care undertaken to the NHS. That's not just in the independent sector at all. And about 21% of all of the independent elective care is undertaken by Ramsay as well. So we're a really, really strong partner to the NHS, and we're not embarrassed about that. We do also provide services to the insurers as well as people who want to pay for themselves as well. But the majority of our business is focused around supplying NHS services.
So Nick, before we get into how do you run an organization like that, that's part of a global group but also has its own distinct elements, as you say, partnering with the NHS. Tell us about you. How have you become the chief exec of Ramsay UK? What brought you to this point in your career?
So I presume this is where your listeners get their pen and pencil out and start getting ready to write something down. That's perhaps showing my age. They might go to the phone or the laptop. Sorry to disappoint everyone, but I've not got a really clear career path that says this is where you end up. So I've been in healthcare for 17 years. Worked in a different independent provider for 10 years, and then I've been with Ramsay for 7 years. 4 years as chief operating officer, and 3 years as chief executive officer. Prior to that, I did a multitude of things: retailing, logistics, call centres, manufacturing. All of those, when I look back though, all of them had a heavy emphasis on service, typically large teams of people to deliver those services, and typically large partners or customer at the base of it. So if you listen to that, there's a lot of similarity in healthcare. I remember my first couple of months starting in healthcare down in the southwest, and I used the term customer. 17 years ago, a patient was not a customer. I was told very clearly they're not a customer. And I'd like to think that the sector's changed, because I think we have to be conscious and mindful of bringing the elements of customer service to healthcare delivery. And that doesn't undermine or demean the healthcare part of it, but delivering it with a real strong angle around customer service, I think, is critical for now. But also the customers of the future are going to demand much more from us as healthcare leaders.
And do you think, I mean, you obviously, as you say, you do a lot of NHS work. Do you think your patients or customers, as you've just said, so I'll correct myself straight away, but your customers, your NHS customers, i.e. individuals who come into your units, do you think they get a different experience than if you were having your elective procedure in say a normal district general hospital? I don't want you to tout and say, no, they're rubbish, we're great, but what do you think that difference is around customer focus?
So I'll say a couple of things just to support that. I'm a great proponent of the NHS. I'm a taxpayer. I've used the NHS for services. We've all typically have had will have started life coming through an NHS service as being born, and it has an absolute place. And I think we expect a lot from it. And I know from our business, trying to run emergency services, high dependency, high acuity alongside high volume, less acuity is damn difficult. So I take my hat off to our NHS leaders, but my challenge to them is that how do you differentiate those service lines in effect a large building? The beauty we've got, if you think of one of the largest NHS trusts, it's got a similar turnover and a similar volume of staff as we have, with 7,500 employees, 750 million turnover, but spread across 37 business units. And that allows you to do a couple of things. One, it has a challenge, because how do you get continuity across the whole organisation? But equally, what it allows you to do is then to really focus down your service lines on what you're really good at. So your initial question was alluding to, is there a difference for an NHS patient versus somebody who's come privately? Absolutely not. The clinical care comes first and foremost. From in our organisation, if you speak to anybody at all, it's absolutely about clinical care outcomes before profit. But not be frightened of making profit, because we invest heavily back into our organisation to ensure we can maintain the systems and that. We invest about £50 million a year in just keeping the lights on, the basics of infrastructure. And then obviously we invest in the latest equipment and things like that, and building new hospitals as well. So I think it's important that the customer service element is that feeling you as an individual. And that's become much more, certainly since COVID, it's become much clearer from individuals who are a potential customer, who become a patient, and then become a potential customer afterwards again in the future, have that element of great clinical care, and the individuals take that for granted, and we as healthcare providers have to make sure that we don't treat that disrespectfully. But how you actually deliver and make the patient feel at absolutely the centre of their care, it's individual to them. They're listened to, they're part of, they're taken along the journey, receive the information appropriate to what's, if the treatments are going to go through. Because we need to remember, individuals not coming to any of our facilities, whether it's an independent hospital or a state-run hospital, they don't come in willingly. So there's an element of distress. It's not, in my language, it's a distress consumption or purchase. So we have to respect that the individuals are often mindful and conscious of it's a strange environment, and that's where I think the customer service comes in, not the clinical service, but that real explanation about what's going to happen to you and really treat them like an adult and a human being is critical. Now, so for me, that's where it comes in, from a differentiator between customer service and clinical service. And I think in the smaller business units, we're able to deliver that much more independently, and particularly to that individual.
And is any of that, Nick, associated with the fact that you are, on the whole, I think, doing planned work, aren't you? You're not doing emergency work, and therefore your whole business model is more attuned to ensuring people get there to the right place, so it all runs really smoothly and you're as productive as possible. Is part of that customer service therefore eased because of that particular niche area that you operate in?
I think there's a balance here. So I think if you take back to the point I made earlier about earlier career, absolutely having planned expectations, so you can plan resource, you can plan timings. It's very much a logistics exercise. Obviously, with a very clear heavy bent around clinical services, which then, obviously shrouded in rigorous requirements from people like the CQC now. So it's heavily bound by legislation. But my contention is that you're never too rushed to do great customer service. I'm sorry, you're not. I think treating an individual as an individual, one, helps allay potential problems later on, because there may be, if you're not actually seeing that individual the minute they walk through the door, you're picking up any vibes or any indicators about perhaps any stress issues or anything. They will come out later on, particularly if you're in a scenario where, if you're in an emergency situation where all of the stress and concern about the emergency, all the other behavioural things will come out. So if you're not observing them at the point of action, it's going to create a bigger issue later on down the system. So yes, we have the ability to plan, absolutely, and that should make it much easier from ensuring the right touch points are met through the service process. However, like I said earlier, I think you're never too rushed to actually consider the individual as a human being.
Yeah, and then that's an ethos. So how does the ethos of Ramsay manifest itself? So if I was to be employed maybe in your organization, I wouldn't employ me, by the way, that would be a very bad idea. But if I was to be someone in your fold, what would you hope as a chief executive I would be experiencing from the organization, from my colleagues, as an employed member of staff?
Yeah, and you set yourself up to fail here, don't you? So I'm not,
Of course.
I'm not unrealistic to not know. It doesn't always work, and I think that's probably one of the elements of leaders in healthcare, that constant drive to want to do them small iterative improvements. So the process that we employ from engaging individuals starts from that first connection, and it can be through families and friends, it could be through other colleagues with us, or it could be in more public media, so it may be online adverts and things like that. So that first interactions is as important as all the interactions you come through the process, because each one could be a switch off. But also, that's a relationship if you're looking to recruit and somebody's looking for work, you start to build a sense of each other up. So from our perspective, it's making sure we've got real clear descriptions of what the roles are, what the packages are, how the organisation works, the culture. So that's all that early interaction, whether it be online or face-to-face or through written correspondence. It's got to be consistent. because you start getting an impression of the organisation. If you set expectations of coming back within a certain time frame, or to share something or receive something, it's being really on the ball and making sure that you're doing that. So that's a point one. The next part of that first interaction, now you're getting close to looking to see this individual looks like they've got all the right practical things against job roles and things like that, which we compare to perhaps the individual's job description. It's our first conversation, setting real clear expectations as an employer, how we operate, but also to really get a sense from the individuals. Sometimes people will not fit our organisation, and we're as proud to make sure that we're honest with people and just say, it's probably not the organisation for you, as we are proud to welcome people on board. And that's important, because if you don't recruit for the right behaviours, they will not be fixed by the process. So you really, we're looking for individuals who've got the same ethos around values, but particularly about care, and particularly about delivering service around care. So that's getting somebody into the organisation. Then the experience of onboarding, you should be supported by real clear induction plans, getting buddies attached to you, getting all your first year mandatory training, made it easy. So all that first 3-month period of, my God, what have I done? Where am I? We're really trying to take away some of the pain points of making sure we recruit people on having the skills. And if we know they have some requirements to be built on, that'll be built into their development plan. But initially, you are recruiting somebody on values and behaviour. That's in our organisation. So I would hope anybody that's joined us the last 3 months will describe that experience to you. And then once they're 6 months and 1 year into the organisation, I would expect them to be able to describe team, care, interest, so the team, people pay interest in each other, and an organisation that absolutely welcomes people of difference, is fully inclusive no matter what those differences may be. And in fact, we do try and celebrate difference in individuals, because then they were all human beings with a long history of story behind us that made us into what we are today. Hopefully that gives you a flavour of that first period of time with us.
And what's fascinating to me, I've had the privilege of, on these podcasts in series 1, talking to 11 chief execs on the NHS, and we chose them because their staff in the NHS staff survey, which you'll be au fait with, said they were best in class. I could have been talking to any one of those and they would have described exactly all those elements, which is people first. You can teach skills, go for behavior, go for values, go for care, set clear expectations, which is what you've said, and be brutally honest that sometimes people aren't right for the organization. So I'm fascinated that that's very similar to the good organizations in the NHS. So you must be pitching yourself in quite a competitive market for doctors, therapists, nurses, allied health professionals against others that are doing the same thing as well.
Yes, I think there's a couple of points to that. Unfortunately, it's not consistent across the whole of the NHS, and that's not a NHS bashing, but there is pockets of excellence, and they absolutely are. And because of our spread around the country, we get to work in those partnerships as well. It's because they welcome in everybody as part of the health system. And equally, we work in some areas where they don't. And from a recruitment perspective, that's quite an easy cast when you're looking to recruit. But what I would say as well is that we are a very small employer in the total health economy within the market. A typical trust to be employing 4,000 to 5,000 people. We're talking hundreds, and they're not all healthcare professionals. Some of them are admin as well. So it's quite a small pool in that respect. But also we take a real responsibility in how we develop our own teams, through apprenticeships, develop our own nurse skills. And we know they will leave us because they need to go and get broader experience in different parts of the health system. And we will receive them back in the future when they've had some of that experience and come back into our organisation for different experiences. So it's a two-way. It's unlike some of the rhetoric you do pick up. It's not one-way system. So we take that really, really seriously.
Yeah. So there's some different dynamics. I get that. And if you're up against a large organization that has the facets that I just described, and I take your point. That's why we chose 11, because they were standout organizations. You're going to struggle in those areas, but in other areas that might be a little bit easier. You have a niche you are.
Yeah, enough to talk. I would say in those areas where there's a strong leadership group in the state system, I actually think it's the benefit of all of us, because what happens is success attracts success. So actually having a really good independent capability alongside a really good state system is good for all. It attracts doctors because they've got choice then if they want to practice privately as well as in the state system. It allows healthcare professionals to potentially go and learn some new skills in either sector if they work well together. So actually, for me, systems work alongside each other in a workforce perspective are absolutely, it would be fantastic. And I think that would help us all to grow the people's aspiration to come and work within health rather than it being competing with each other for the workforce.
And then thinking about your role then, Nick, you're accountable. I presume you're accountable to a UK board probably, but you're also accountable, I imagine, to the global infrastructure. You've got, and I was just looking on your site. I mean, let's just take you go from Cleveland down to the southwest, don't you? So you've got a real spread of geographies and those 37 centres. How do you, as a independent sector chief exec, kind of know and maintain the culture that's good in all of those 37 units?
Yeah, it's a great question, and there isn't one simple answer, and sometimes you miss the tricks as well. But I think there's several elements that bring to this. There's the formal, we hold team surveys annually. We have an expectation of the number of people who partake, as well as scoring, the scores on the doors as such, particularly around engagement with the organisation. But that's the more formal part. For me, there's the informals where you really get a sense of what's going on in the organisation. Sometimes it comes back through feedback from customers and patients where we've not got it right. I'm really pleased to say it equally comes back when we get lots of feedback saying we have got it right. But as with a global group, the way we run our organisation, I have high expectations that the local teams run their local business. There are brand elements that we try to maintain, but there is an expectation that the local leadership, the local teams work within their local community and deliver great service, so they become self-accountable. So the softer things are we keep in touch with each other to get that pulse check. My exec team are very, very visible. We actually have 6 clusters we've grouped them into. So each of the exec has a responsibility. They partner with a cluster. So they actually join for local meetings. They perhaps with the capital case, they'll work alongside the local teams to put, to how to get a capital case, but really try to understand from an exec perspective, are things landing well? Are the things we need to do different? But also it allows communication upwards and downwards. But the core of all of this is we've got a really clear strategic direction. It's a one-pager. It's got a group one page. Every exec function lead has a corresponding one page that feeds into that to show that goes down literally to every hospital. So any individual in our organisation can look and say, right, what's the group's objectives are to do X, Y, and Z, and people and culture are part of that measurement. They can see right through the chain, right down to their local hospital about what that local hospital's about and going to do to try and deliver that. So it's the consistency of message, just no matter where you are in the organisation, and they're all metric driven. And then the final part is that myself, exec colleagues, we expose ourselves to our teams in many ways. One is lots of regular visits. Culturally, we are very heavy on being out in the organisation and visiting our hospitals. The second part is that we hold, we have the normal weekly newsletters. We've got Workplace, which is a Facebook for workplaces, where it's publicly open to anyone in the organisation to post things, to ask questions. We have the monthly meeting with the exec where everybody in the organisation is invited in. It's recorded, it's published on Workplace so everyone can see it. Got a whole range of things that we try to bring to, and it's about living what you talk up through. So it's not just about sitting on the end of a phone and me pontificating, but it's about exposing yourself to when you don't get it right and being able to, whether it be meeting with a patient, whether it be meeting with our teams, that you're seen as part of the team and not just a remote organisation. So we try and keep our organisation fairly flat because that enables then that connection. So the board to ward to board approach is pretty rapid. if something's not right, I will get emails from team members saying, do you know about X, Y, and Z? Or if you want to applaud one of their colleagues, they'll do it that way as well. So in that respect, I'd like to think we're a very open, and it gives you a good pulse check alongside the more formal measures.
I guess interestingly, that's a very scalable model, isn't it? Because you flatness devolving responsibility. I guess the thing that was going through my head as you spoke, though, Nick, was that means that you are delegating authority and responsibility, yes, within a framework, your one pager and your cascade, but are you investing? I mean, and I suppose it's the question: how much are you investing in leadership to get that right? So it's the devolved element for each unit. Because if that local leadership isn't right, you then immediately have a fault line in that model, don't you?
Absolutely. Yeah, and it's an old adage, you're as strong as your weakest link, and that is absolutely true. So we've got the I suppose it's the formal, which is if people listen to this, you're going to hear key performance indicators mentioned. I'm not a huge driver of a whole range of dashboards and everyone's getting measured by reg rated, red, amber, green constantly, but there are critical indicators, which is what they originally set out to be, that indicate the health of the organization. We have 8. 2 are people focused, 2 are customer focused, customer and patient focused, 2 are business efficiency focused, and 2 are partnership focused. Everyone in the organisation gets to see the dashboard where each of our units are against those metrics. They're transparently produced. They come from data within our organisation, and they are there as indicators. They're not there as ultimate fail or succeed, but they're absolutely there to make sure that we can mobilise support around teams where they might need some support. I mentioned earlier, we work in small cluster groups. These are typically 6-ish hospitals. And what that allows them to do is, one, to be self-supporting, but also it drives a little bit of competition. And also what it really does drive is sharing best practice. So there's some of the elements. We clearly have very, very formal governance process around clinical care outcomes, because we're all registered from a CQC perspective, but also it's what our patients expect anyway. So there is the formal, very rigid process of managing performance, but it's absolutely set aside with the softer expectation that as leaders you run your own business, but also you're part of a collegiate group. How do you get that? And that's quite hard, because we employ individual leaders to be sort of alpha leaders. They want to be best in their class, and now you bring them together to share that. Well, I want to be best in class, but I want my class to be the best as well, and how to grow that as well at the same time. That's a challenge. I don't pretend it isn't. And bluntly, if it's not working, at some point there is always that open conversation, which allows us to both as leaders talk to our individual leader, and they have the right to and feed into that, where sometimes it doesn't work, and support can be put around people from a development perspective. But I do have a particular high expectation. When you're given that freedom, treat it with respect. There's lots of resource in the organisation to support, so like I say, treat with respect. So that's how we tend to operate our business.
And there's some really, I think great leadership principles in there, in terms of freedom, support, but accountability and focus as well, with the indicators being on the right things rather than erroneous things. That makes me think you must have learned how to lead and then lead the rest. So how have you learned to lead in that way?
I smirked to myself when he was saying it, because this is the question I'm dreading.
What, talking
like,
about yourself? Yeah.
Well, also, I'd like to think I was very clever and I'd worked it out. From an open perspective, some of it's been fumbling around. There's not been some very, very clear career path. What I find myself, I'm very attracted to mixed skilled organizations with large customer bases. I enjoy that environment, so I've learned that from myself. I've got a very, very strong values led approach. I'd like to believe, and I hope that's what the team would support us, I have bags of humility and a ton of resilience, because that's what so I play to my strengths. So I think from how do you bring that into an organization and into the role, is be yourself. You'll be spotted within 30 seconds if you're not being yourself. So I think there's something, and there's lots of books written about values-led leaders now, but I think your teams will pick it up very quickly when you're not being yourself, and that sometimes means getting it wrong. And I quite often get it wrong, and I'm quite open to say, it's a learning experience for me, this one as well. But if you don't enable that two-way adult to adult conversation to take place, if I don't exhibit that and that element of humility, nobody in the organisation will, because people will watch and observe what goes on around them. I don't know if I answered the question, but I think so. It's them indicators. I tend to be attracted to businesses where you're able to deliver leadership with them as the core element of the organisation.
Yeah, and you were talking about retail, manufacturing, all the areas that you've worked in. I presume, heavy learning from other sectors and logistics that you could then bring into this role in that respect. I mean, that's years of understanding and learning, hasn't it?
Yeah, I've been lucky. I've had some probably 3 or 4 people over my career who've bluntly given me a kick up the backside when needed, and equally put a hand out to just say, perhaps I could help you with this, or observe. And that's been really interesting for me, that whether it's to correct something, or whether it's an offer of help, or whether it's to take it to the next level, they're all elements of I used the word alpha earlier. We tended to attract leaders that are on their game and want to be measured by performance, but sometimes that means talking about poor performance or underperformance is quite uncomfortable. I've learned from my career that actually they're the best conversation you can have, and it's when you're open to them, and the person who's delivering them is doing with humility, but also they're doing it with respect for you. Do you know what? They're the best learners. So that I think I bring that to, and certainly has shaped me as a leader as well. But also, the sectors I've worked at, I've seen some really poor practice, some really bad behaviour, and some things that are real markers for me that I will never, ever be that type of leader. And it does catch me sometimes if I've slipped something and someone's pointed something out to me. And I reflect back, and it's, crikey, I saw that in exposition when I was in another organisation. I knew how it felt. So, you can learn from the good and the bad. And I think hopefully that gives us but you have to be open to that.
Always tough to go through, but really important in forming us to be something different at the end of it. Yeah, I can identify a few of those myself, but not for now. Nick, just then thinking about, you've been at this a good while now. You've been at Ramsay for, what did we say? I'm just looking at my notes. Was it 15 years?
Yeah, 7 years at Ramsay.
7 years, and you've been in the healthcare world for 15 years.
Yeah.
So that's in an organization such as Ramsay and the ones you've done before, which is, heavy duty, it's customer focus, it never stops, does it?
Yes, yeah.
How do you sustain yourself then? So as a leader, how are you enabling you to be able to do this job well without, frankly, becoming unwell in the process?
Yeah, and COVID was I was chief operating officer during COVID, and I think it was an interesting time when that sense of feeling responsibility for a whole organisation. And you're stuck in a room looking down a camera at hundreds of people. That was a bit of an eye up. You can't take it all on yourself. So there is some, I've got a couple of techniques for balance. They're not all healthy ones, but I try to keep balance. But I think probably my biggest learning, Matthew, so I am later in career rather than earlier in career, is I'm not a superhero. I'm Nick Costa. I try to be genuine and be me. And I think that's part of my, probably part of my release mechanism, that I don't beat myself up too much. I do overthink about, if there's a nice gnarly challenge that I want to get in my head around, I'll work that through in my brain. But what I'm really mindful of is that, how do I bring the team in? I've got much better people around who I work with, either in my team or in the organisation or in other organisations that have probably been there, seen it and done it. So again, that's probably a factor of age. So I think it is having some humility. There is something about the leader who believes they know everything and pervade that way and present themselves that way, I think loses the audience within seconds. I'm not saying my way's perfect, but my control mechanism for, keeping going at it. I love to hear positive stories, whether it be from team members or whether it be from patients. But I actually bizarrely, I like to hear some of the bad stuff, because it's like, great, what have we learned from that? Why did the system go wrong at that point in time? Because it shouldn't have done. So I like the challenge of how do we fix things. So that's
And
me.
as we come into the end of this conversation, Nick,
Yeah.
which has been fascinating, talking about fixing things, there's been we're having this conversation a few weeks after Lord Darcy has written up a kind of very formal, almost diagnostic of the healthcare world, not just the NHS, but our general population and all other facets. What are you then looking forward to in the next kind of few years as we launch, early days of new government? You've already said you're working in partnership with a lot of NHS organisations, delivering an important aspect of elective and other work already on behalf of the NHS. What are you looking forward to, and maybe what do you think people like Ramsay and other organisations can do more of?
I think there's a couple of parts there. My hopes are that we might turn the corner on this rhetoric around independent sector state system. We are part of a health system. And the way and I think Lord Darcy pulled some of this out as well, the way some of the structures work is that you've got doctors coming through now who perhaps never see some of the elective procedures because of the way they're structured. What a great learning ground to come into the independent sector and learn it. But it's not at this point in time, it's not a natural state of affairs. So I do hope that over the coming period of time, we start seeing it being acceptable and seen to be exemplar, where health systems and local communities work together, whether it be around training, manpower planning, whether it be about volumes, whether it be about clinical care path, a whole range of and I think that will then enable an efficiency uplift that will enable funding and focus to go into the prevention space. Because I think we all accept there's an issue around prevention, but when do you put the money into prevention versus putting it into elective, care delivery? And I think we have to do both. And I think we as the independent sector can play our part in sharing some best practice, but also in maintaining high volumes, fantastic outcomes at a good unit of cost, enables the money that's spilt out from that to be then spent into the areas that will stop people ever needing to have healthcare needs. So that's my hope. I think there's one missing part, which is probably the way not to finish this conversation, but I think the language I'm hearing in the early days is about accountability, and that's one key thing I would say in our organisation. I have high expectations of myself and the team. We do everything we can to enable individuals to be at their best, but there is an accountability and a consequence to things. That doesn't mean sacking somebody, but it means facing up to things when they don't go right. And that's, I have to say, that's not consistently delivered. And I think if we start seeing that consistent consequence, it will enable leaders to start saying, do you know what? I don't know the answer to this, but I know somebody who might. And it might just get the health system starting to work better together.
Yeah, interesting. And I don't think that's contentious at all. I mean, accountability is just one dynamic of leading well, isn't it? And knowing individually, am I doing a good job? Am my team doing a good job? Am I doing it on behalf of the sector? And as I'm sure as you've said ably, I think that's very similar for the statutory sectors as it is for the independent sectors.
Yes.
There's nothing wrong with that, but it's a word we seem to have problems with and
We
the
do.
connotations. But my job title is both chief executive and accountable officer. So I am accountable, and I share that accountability through my organization as you do. Yeah. Nick, it's been fascinating listening to us hearing more about Ramsay and their amazing reach across the globe in 60. That's such a young organization in many ways, but doing amazing things across multiple jurisdictions. Your journey into healthcare, 17 years in the independent sector, and your background, how that's informed you to work. I was grinning when you were describing the approach of how you employ people, the culture you like to maintain, the accountability, the leadership leadership you develop, and how you've learned to lead, because I think there's some absolute universal applicability in there. But it was also really interesting to see that provocation of how do we break down those barriers so the independent sector isn't seen as something tough and difficult and separate, but it's a partner to
Yeah.
deliver great care, and maybe using the best of the independent sector to be of benefit to the whole population, and improve prosperity, improve outcomes, and the government mantra of growth as well. Nick, it's really been fascinating. Thank you for joining me on Leadership and Culture in Healthcare. And I wish you well as you dot around the country, and all your units and your clusters in the Ramsay Group.
Matthew, it's been a pleasure, and thanks for inviting me.